Hello, I'm Dr. Marla Shapiro. Today we're going to talk about the patient who requires hot flash management but for whatever reason is refusing menopausal hormone therapy. What are our options? And who better than to talk to us than Dr. Wolf Utian. All of us know Wolf as the Executive Director and Founder of the North American Menopause Society, and he is also Professor Emeritus at Case Western Reserve. Welcome.
Thank you.
So, there are lots of patients who don't want menopausal hormone therapy, but just a brief word on the woman who must not have menopausal hormone therapy.
Right. Well, the women who don't want probably are terrified by media reports and so on. And that's something that you're not going to change, probably. Mm-hmm. The woman who should not take hormones, certainly the woman who has any estrogen receptor positive cancer, breast cancer, uterine cancer, a woman with acute liver problems, mm-hmm. a woman with maybe a major history of previous deep venous thrombosis. Most of the other reasons not to take that have been historically used, diabetes, hypertension, are not true, number one, and if they are, they would be just relative contraindications.
So after we've sat down and had a conversation with a woman who is someone who can but doesn't want, and despite reviewing all the evidence, still requires treatment but really is saying no to menopausal hormone therapy, what's in our armamentarium that has evidence behind it?
Well, this is the real problem, and NAMS has just come out with a position statement published in Menopause. And the truth is that we can divide them out into the pharmacologic, FDA-approved products, and then perhaps the others.
So let's start with the approved products.
Right, and in fact there's only one. So that's paroxetine, which is an SSRI, low dose, and probably any of the SSRIs would be equally effective. Non-approved drugs that have virtually the same effect as the paroxetine would be drugs like Gabapentin, and perhaps just a little less effective than that would be clonidine. Now, let me try and put that in perspective, because on a scale of 0 to 10, hormone therapy, which is the most effective, would be around about 9.5. Placebos, which is always a placebo effect always present, would be in the order of about 3 to 6. Mm-hmm. The SSRI paroxetine in the clinical trials was around about 6.5. In fact, gabapentin was about the same, except that in the comparison to the placebo in those trials, the placebo effect was higher, so that there was no statistically significant difference.
So when we talk about looking at SSRIs, such as the medication that you're talking about, dosage, what type of dosage are we looking at? Well,
we're looking at there's only one approved mm-hmm. product, and that would be the low-dose paroxetine. Effexor, which is an SSRI, SNRI, I think it's about 0.75 milligrams.
So, and when we come to something like gabapentin, how do we go? Because that's a drug that you can go anywhere from 100 milligrams all
right.
the way up, but
and
worry about sedation.
Right. And I think gabapentin has the one advantage in that it does have a sedative effect. One of the problems women complain about with vasomotor symptoms is sleep disturbance. So it's not such a bad idea to take 100 milligrams of gabapentin at night, and it might actually help with sleep as well.
So once we leave these medications, and then there are a
right.
host of other SSRIs that are used off-label, low dose, the caveat for women on tamoxifen and doing something with paroxetine, that's a medication that the two should not be used together.
Well, there are potential problems of drug interactions, and I think the sad message is how little we really have outside of hormones that are really effective. Beyond the pharmacologic agents, we look at the other things. For example, the nutrient supplements and herbal products.
So this is a huge market with women that are often trying things that
right.
are untested, but have the name natural beside them, and they see that as being without harm.
Right.
Do we have any evidence that any of these products are useful?
We looked at that very closely, and in the NAMS position statement, in point of fact, we say that virtually all the herbal products do not work. There's no scientific evidence to say that they work beyond a placebo effect. And we can speak about the placebo effect. I don't have a problem if a woman goes into the health store and takes one fancy labeled bottle and it works and she's having the placebo effect, if that's beneficial to her, that's fine. Where the problem lies is that if she doesn't get benefit with one and she starts going from product to product, if she's not having the placebo effect with one, she won't have it with any of them. She's just wasting her money. Point of fact is most of them do not work. We do know that perhaps high-dose genistein, which is a component of soy, might be effective, and certainly there's evidence, we say preliminary evidence, that a metabolite of diazein, which is also a product of soy, diazein gets converted into S-equal, and the S-equal may be effective in alleviating hot flashes.
And these are products that we can find over the counter?
These can find over the counter. Now, in Asian populations, the majority of women are able, they have the gut bacteria and the enzymatic ability to convert the diazein to S-equal. Less than a third of North American women are able to do that. So most of them are what we call non-producers for the conversion of diazein to equal, and that's probably why soy products don't work in most women here.
So a word about all the other things that are out there: acupuncture,
right,
cooling devices, paced respirations, biofeedback. Does anything work?
Well, the only ones that we found evidence for were cognitive behavioral therapy, and what that really is, it's a combination of paced respiration, psychological counseling, sleep hygiene education, relaxation techniques. It's a whole combination of things. There's some evidence that might be effective. And the other one that might be effective is hypnosis. But again, this is much more complicated. It requires a woman going to a skilled hypnotherapist and then learning perhaps some mechanisms of self-hypnosis at home. These are not easy things. I think the message that virtually all the others, there's no evidence to support any of the ones you mentioned. So the message that we're getting is that we lack research in this whole area of the cascade that leads to the hot flash. We know a lot about the actual process of the hot flash, but we don't understand the chemical cascade. And if we can get to that single point of knowing what chemical from point A to point B is and develop a ligand that works at that point, we'll be able to have an effective therapy for vasomotor symptoms. But that's going to take time, money, and research, and it just doesn't seem to be happening.
Thank you so much, Wolf.
My pleasure.